So she said there are a number of graduate students in the audience who are interested in STI research and wondered if you had any words of wisdom to share about going into the field, clinical, public health, or both. Whatever you can share. Pearls of wisdom.
Yeah. Well, it's a huge issue in the American healthcare system because of the number of cases and the escalating problems that I had planned to talk about. There's always something new to say, and that's what I was hoping to talk about. And there's a couple of things that I find interesting. One is this: AIDS is a huge issue, and it's a sexually transmitted disease. STIs have been around for a long time, and STIs tend to be secluded from HIV. So HIV providers have their own meetings, have their own literature, talk to each other, have their own care programs like ours over at Hopkins. Like the CROI meeting, which is the biggest meeting we have, doesn't have STIs at it. And that separation, I think, is interesting and probably not healthy for either group. The second thing I would say is, don't forget, we're about to have a huge change in the healthcare system in the United States. And it's going to move toward, of course, the Affordable Care Act, or the Obama plan, which is going to change it in a dramatic way, the way we do business. How it will affect providers, public health officials, and so forth is not clear at all, at least not to anyone I've been able to talk to. In fact, I have a slide that has the healthcare system with a black box under it, because I don't know what's going to happen. And but I can tell you this: there is a thought that much of what's done now in STD clinics and HIV clinics is going to be turned over to primary care clinics, the health home, if you will, with the assumption that they will take over that what used to be specialty services. Now, whether that's going to happen or not, or whether that's a good thing to happen, is not clear. The third thing I would say is that we are in the era of enormous amount of data. And the reason is because, first of all, the internet and all these things have changed medicine so much in terms of collection. Now, that's obvious to everyone. What's less obvious is that the whole healthcare system is going to an EPR system that's national. And what that means is when I see a patient in the clinic, now I turn around, I talk to the patient, it's face to face, and I say, how are you today? Tell me about your life. It's going to change. Now I'll be looking at a computer, and I'll say, have you ever been vaccinated for hepatitis B? And then I'll look it up on the screen. It's going to be much different at the provider level. But ultimately, it will be good for medicine. In this sense, it'll be a national EPR system. And therefore, you'll have access to an enormous database. It won't be the Johns Hopkins database. It won't be some other, the Baltimore City Health Department database. It'll be a national database with a Baltimore component, a Hopkins component, and so forth. The amount of information you're going to get from that is just going to be huge. And therefore, if you want to know if people respond to this kind of a drug for gonorrhea, for example, you may have access to thousands, millions of records. And you'll be able to see how people with gonorrhea are treated, whether they get a culture, whether they get the right drug, whether they respond. You'll be able to get all of this information. It's going to be a massive amount of data that's going to be generated out of the database. Now, we've got to be a little bit careful about how we hook these things up. I have a slide that I didn't show here, but it shows this. It shows global warming on the x-axis and the number of pirates in the world. And it is the tightest correlation you could ever imagine. I mean, it is a perfect straight line. And what you could say is, well, global warming has made pirates extinguished. I mean, they're gone. They're practically gone. And of course, that's crazy. That's nuts. But so you have to be careful about how you put these numbers together. But for the people that work on data analysis and planning and whatnot, it's an enormous opportunity. So I think what people in public health and clinical structures are going to see is an enormous change in healthcare delivery, and the amount of data that we work with over the next 5 years. And the transition is going to be rough. But once we get to where we want to go, I think it will be an enormous benefit. I'll be able to see, if I have a patient that was in Los Angeles for health care a year ago, I'll be able to get all those records. You know how hard it is to do that now? I mean, it's just awful. I can't get them. And if he had an MRI then, I now have to repeat it again because I don't have it. So there's going to be some real redeeming benefit from that. But on the other hand, we've got to be a little bit careful about how we use some of the data.
We're going to just go ahead and record. It won't be webcast live, but it'll be recorded and archived for later.
If you have time. Are you able to accommodate an hour and a half starting now?
Well, it's supposed to be an hour, so we should.
Yeah, do I have this so I can advance slides yet? Is there any way I can advance a slide?
Slide thing, projector, forwarder. Instead of doing this, you must be on first.
That doesn't work either. Oh, okay. This one doesn't work then. Yeah, it does now. Okay, thank you.
Thank you, sir.
Okay, all right. I still get an hour and a half?
You do.
You have as much time as you need.
Sorry for the people in the audience. So I'm going to talk about hot topics in sexually transmitted diseases. And this is the slide you've already seen. And I have no sins. So this is kind of an outline of what I'm going to talk about. And these are, you'll have to excuse me, these are the things that I find fascinating that are kind of new and exciting in the field of STIs, including HIV. These are the main pathogens, and I think everybody knows this list, but there are a few of them that I think are especially exciting, and one of them is the gonococcus, one of them is HIV, one of them is hepatitis C, which is arguably on the list, but I'll talk about why I mentioned it, and then human papillomavirus. And I've selected these to be the focus of most of the talk. And specifically for HIV, we now know that we can treat it and treat it successfully, but we can't cure it. So the plan for the future is to cure and prevent, which makes sense. Treatment is done. It's been done since 2008. For the gonococcus, as you've heard, the main problem has been resistance. And it's going to get worse. And we're talking about a period in which there is no treatment for the gonococcus. For human papillomavirus, it's the vaccine. For hepatitis C, I put in parentheses because it's not usually considered a sexually transmitted disease. It is, but it's not very efficiently transmitted. But it's a very exciting time for hepatitis C because it's now about to become a curable disease. So the epidemiology kind of shows a stereotype pattern. It's sort of the East Coast down around the South and up through California and Oregon. And this is the rate for chlamydia, this is the rate for gonorrhea, and this is the rate for syphilis. And you can see the states are pretty much the same. If you've got one, you pretty much got all three and that's what that tends to show. I might mention that Maryland is one of the hot spots for all three. Here's where we are. In terms of AIDS and HIV infection, we're number 3 in the country. For syphilis, we're number 2. For the gonococcus, we're number 16, so we're about halfway down, or about a third of the way down. And for chlamydia, we're number 16 as well. So we've got a state that has a lot of hot parts on this topic of STIs in terms of problems that we have in both Maryland and Baltimore specifically. Now, how have they changed? They've changed in a way that's kind of interesting to me. Chlamydia trachomatis has increased by 49%, but the gonococcus has decreased by a third. This is over a 10-year period. Syphilis is way up, and that sudden increase in syphilis is very bothersome in terms of what that disease does. Now, in terms of the gonococcus, the big problem with the gonococcus is epidemiology and primarily resistance, because we're now getting more and more problematic cases. This is the epidemiologic curve, and you can see it peaked in 1976, then it came down, reached a plateau, and now it's kind of steady. It has not increased much. This is the rate of gonorrhea by race, and what it shows is African Americans, black people, are way up at the high risk level. And if you look at that line across the top and compare it with whites on the bottom, you can see the enormous risk associated with black race. We're not sure we know why. It does not appear to be behavior, sexual behavior. It may be that it's within the population. So it's like any other disease, like cholera in Haiti, for example. I mean, once it's there, then more people are exposed and more people are infected. We don't know. That's not necessarily the answer. That's one of the possible answers. This is the rate of Neisseria gonorrhea in MSM. MSM is a huge risk. And this is the gonococcus in MSM, and you can see that rate just goes up, 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 up. And again, I'm not sure we know the reason, except here it does appear to be risk associated. All the STDs seem to be magnified in the MSM population. So in that way, to me, it's a little bit different. So here's what it looks like in terms of the big picture of the gonococcus. It was came down to a level at about 1996, was flat, and then increased a little bit. You can see the African American to white ratio is almost 20-1, a huge difference. The resistance story is this. The gonococcus is one of those organisms which, when treated, no matter what you throw at it, it gets resistance to it. So it's not like chlamydia trachomatis, which in terms of resistance is really boring. Because it doesn't seem to change, despite an enormous number of cases. But the gonococcus, because of its inherent factors, seems to be very prone to resistance. So, ceftriaxone was cefixime, but got resistant to that. Azithromycin, the quinolones, especially in MSM. And now we have ceftriaxone resistance, which was called the last hope. So here's what it looks like, and you can see, you don't have to see all the little numbers, but this is resistance of the gonococcus, And if you showed this for chlamydia, there wouldn't be any juxtaposed lines because that doesn't change. And you can see the end of the curve shows the possibility of untreatable gonorrhea in the future. Scary. Especially when you consider there's 700,000 cases a year in the United States. The other problem that we have, which I think a lot of people in the audience are aware of, is doxycycline, the lack of the drug. And we periodically have this happen. Like right now, we're running out. We have very little access to INH. We're having trouble getting PPD material. You know, we never used to have this. At least I don't remember it. Now we seem to have even a drug that seems to have been around forever and is easy to make, doxycycline. You look at the bottom line. A $4.60 supply for a 60-day supply is now $165. I mean, that's ridiculous for doxycycline. It's not going to necessarily stay that way, but it will happen with another drug. So here's the current recommendation for the gonococcus. It's at the bottom, and that's ceftriaxone, so it's got to be an IM injection. You know, before it was oral. Now it's IM. It's a shot. And when we talk about giving something for the partner, that becomes a real problem because you can't give them a syringe full of ceftriaxone, which is the preferred drug. And then you have to, of course, cover chlamydia with azithromycin or doxycycline. Now, doxycycline's a problem. So you may have to give them the 1 gram of azithromycin. How many people in the audience have ever taken a gram of azithromycin, the Z-Pack? I mean, that's tough. There's a lot of people that give it back, and they vomit. They vomit it. And sometimes we are forced to give 2 grams, and there are few stomachs that can take that. This is an article, a medical article in the New Yorker, which I strongly recommend. It's a great read. It's by Jerry Grobman. And it's about sex and the superbug, and the superbug is the gonococcus. There's a lot of superbugs now. Clostridium difficile is a superbug. Staph aureus is a superbug. The carbapenemase producing gram-negative rods are superbugs. But the gonococcus has now joined the club because of resistance. This is a very intriguing story about a number of facets in sexually transmitted disease, written by Jerry Grubman in New Yorker last year. And I called him to find out how he knew this. He winds up, you have to read the whole article, and at the end you get the punchline. Where did this awful strain of gonococcus, Neisseria gonorrhea, come from that was resistant to ceftriaxone, the last drug standing, if you will? Well, he said in the article it was a Kyoto prostitute that had oral sex, and that a Neisseria in her throat normal flora transmitted the elements that made it resistant, made the gonococcus, a Neisseria gonorrhea, a resistant strain. And so I wanted to know how he knew that. What he told me was that I had to read a paper by Waino, and I'm not going to show the paper by Waino, but I have to tell you, that's one of the most magnificent molecular reviews of a bug transmission, a bug resistance transmission that you ever want to read. And that was traced. And then, of course, that strain that was found in Japan was subsequently found in France and Germany in 2009. Now, once you get strains of gonorrhea resistant to our drugs, they go every place. You can't keep them geographically penned in. And so here is the most recent MMWR on the Gynococcus with resistance to cefixime, which is oral and used to be recommended until we had the resistance to that drug and had to switch to ceftriaxone. But now in the dark blue, you can see ceftriaxone has become a problem, or is becoming more of a problem, and that bodes a very ominous prognosis. You and I know the ceftriaxone is going to go. And then the question will be, what's left? Now, there is a I don't mean all the cards have been played quite yet. There is a thought that spectinomycin, a drug that we haven't used for years, and gentamicin may still have legs as far as the Gynococcus is concerned. But nevertheless, this is very disturbing and has to be watched. Now, I'll tell you another problem with this, a big problem. When we see patients in the clinic with gonorrhea, what do? We prove the case with a NAT, a nucleoside amplification test. We don't culture the organism, and therefore we don't know what it's sensitive to. So the way we currently do business is for the majority of cases of gonorrhea that we see, they're tested, treated empirically, and we don't know if they're resistant. Now, there are sentinel surveillance systems that are set up beautifully by the CDC so that we can keep track of that, at least in some sites. So here is the recommendations regarding Neisseria gonorrhea. Screen all sexually active MSM and high-risk women at exposed sites at least annually, and that means genital exams or cultures or tests, and then also pharynx and rectum if those have been exposed. The treatment is ceftriaxone, as I mentioned, plus azithromycin or doxycycline. The alternatives, if they're allergic to ceftriaxone, or if there is a reason that you don't have it, which has been a problem sometimes, as it is with doxycycline, then cefixime you can use, but you have to use the azithromycin doxycycline, because azithromycin plus cefixime may be okay, because few strains are resistant to both. And the bottom line is probably the most important, and that is test of cure. Because we don't know if it's sensitive or not, we don't know if they're going to recover on the basis of their empiric treatment, and therefore we have to do a test of cure at 1 week. Now, I thought this was kind of interesting. It's a very recent publication of experience in Cincinnati, but I think it's representative of most of the places that do STD or STI public health services. So what they wanted to find out is how often are we right. Don't forget, the patient comes in, we get the specimen, the patient's gone, and we don't know if they will ever come back. So there's a big incentive to try to treat them at the point of care. So what they looked at in Cincinnati was how often they overtreated, and that is treated for gonorrhea when they didn't have it, or undertreated, that is did not treat when it was there. Well, you can see they were correct 50% of the time on the basis of clinical features. They undertreated 30% and overtreated in 52%. Now, all of that is to call attention to a gap in our services, and that is, wouldn't we love to have a point-of-care diagnostic test? Because right now, what is done is the routine is you collect the specimen, it goes to the lab, it gets in an assembly line, and then it is subsequently done, but it's usually 1 or 2 days before it's reported. We would love to have a point-of-care test. A point-of-care test is a test that you and I can do on the spot in the clinic. Does not require a lab, does not require lab equipment, doesn't require a trained laboratory technician. We have that now with some tests. For example, HIV is a point-of-care test. You can tell like that, and it's done all over the world in that way. So the NAT test is recommended. The time I mentioned, the expert is what we're talking about, but it's one of several molecular tests to detect the gonococcus or chlamydia. The sensitivity and specificity is extraordinary. Don't forget, this is a molecular test. You can find a needle in a haystack. So if there's one gonococcus there, it'll detect it. And I thought this was interesting in terms of the outcome of that test when done in this fashion. So the number that were positive for Neisseria gonorrhea and chlamydia trachomatis are shown for men and women. The question was, did they have symptoms, yes or no? Well, most of them had symptoms. But you can see there are a fair number that are asymptomatic carriers, and that's what we talked about before. Number of people that have these, and if you looked at the total number of people in the clinic, the 1,387 men and 1,722, you see that the number that were asymptomatic and positive is actually fairly substantial. So there's an awful lot of people that are asymptomatic, but nevertheless infected. It's hard for the clinician to make a guess as who's really got Neisseria gonorrhea or chlamydia trachomatis. And a point-of-care test would be an enormous advance, and there it is, and it looks like we should have it. We don't have it now. HIV infection is always an interesting story. And here is the X for Maryland. The X is this. The number of cases in gay men has gone way up, and the number in injection drug users has gone way down. And so it's the blue line and the red line, and that's the X. And the slope of the curve doesn't seem very impressive unless you look at the x-axis, but you're talking about big numbers. You're talking about 45% in injection drug users, going down to about 15%. I mean, a huge change. Epidemiologically, a huge change. But you can see MSM has gone from 20% up to 45%. So a big change in the epidemiology, and here is the diagnosis of HIV infection based on race. And again, we see this enormous dominance of the black race, unexplained, at least so far. And then here is the MSM exposure by age. And what you'll notice here is the great increase in young MSM, accompanied by a pretty big decrease in those that are older, 30 to 39. And I don't think we've really sorted out why we have this shift. I'm not sure we know why injection drug use plummeted so much, except for the needle exchange program, which most of us think was really smart as a public health issue. Politically tumultuous, but nevertheless seemed to make a huge difference. Here is MSM exposure, again by race, and black MSM is very high on this list as it is on the other. So it's a kind of, to me, it's kind of a newly recognized epidemiologically important group. And this is heterosexual exposure, which is, again, dominated by black race. Now, in terms of most of the people, at least in the audience here, are from Maryland, so this is of primary interest to the people in Maryland. Our state ranks number 3, so we're embarrassed by that. We have twice the national average, but we do have extraordinary resources which are mentioned here in terms of the state health department, city health department, the clinical health services. I think most people are aware that the treatment of HIV infection has gone to the point that it's almost a done deal except for the cure. And now emphasis on prevention and link to care. And those are the challenges right now. We've got drugs if we can get people to get tested, engaged in care, stay in care, and take their medicine. So these are the things that I think are important in the field of HIV infection. First of all, the test. Now, in 2005, the CDC said all persons that are between the ages of 13 and 64 should have an HIV test. And if they're at risk, then they should have it annually. Now, the U.S. Preventative Services Task Force came out the next year and said, no. Do risk-based testing. So you've got 2 federal agencies giving very different recommendations. I think one of the important issues for people to remember is that the U.S. Preventative Services Task Force drive payment for a lot of the tests. And therefore, you may agree with the CDC, but you may not get it paid for. This year, the U.S. Preventative Services Task Force endorsed the CDC recommendations. And you I asked myself, what happened in those 7 years that made them change their mind? And quite frankly, I don't think there's anything. I just know that there are 250,000 people that got infected during that period. I'm not necessarily saying it's their fault, but nevertheless, that's certainly part of the equation for getting tested. The legislation around testing is state-based. So in the state of Maryland, we've gotten rid of most of the impediments to doing testing. That long informed consent that looked like a lawyer's edict is long gone. However, the Maryland legislature said you must document, the care provider must document that the patient gave permission. And that, to many of us, is a huge impediment because you can't just do the test. You've got to have somebody write in the medical record. So we had an automatic entry at Hopkins, and now we have to take it out because we have to have somebody that writes in the chart that we told the patient they were getting the test and they agreed to do it. The test itself is changing. The test, when it grew up, was targeting the specificity. In other words, what the CDC said is, wouldn't it be awful if we told Joe Blow he had HIV infection, he didn't have it? Well, now it's changed. The priority is sensitivity. Nobody has a positive test anymore. I mean, I've been doing this a long time. I've not heard of a false positive test for HIV. If the screening test happens to be positive, they'll go to a clinic, they'll get a viral load, a CD4 count, and they will have confirmation whether they have it or not. So that's no longer an issue at all. So the testing objectivity has changed. And where you get it in a hospital, you can get it in a clinic, you can get it in the back of a church, or you can get it at home. Who gets treated? The U.S. Health Services guidelines, this is the DHHS guidelines, recommend, and IAS USA, all guidelines that are respected, New York State, DHHS, and IAS USA all say if you have HIV infection, you should be treated with the antiretroviral drugs. So it's no longer the CD4 count is this, and therefore you can wait. There's no CD4 count that is thought to protect you. Now, I wanted to say something about the test because I think this is important. You've all heard about the Mississippi cure, the baby, right? The baby had the virus transmitted at the time of delivery. They discovered the mother was infected at the time of delivery. They tested the baby, and the baby was positive. They gave the treatment immediately. And for some reason, Dr. Day, bless her heart, got viral loads about every 3 hours on the baby, and it just went away. That virus was gone. And she came back, she disappeared from healthcare, and came back after no treatment for 2 years and has no detectable virus. Now, she does have virus sequestered away in some memory cells that can be dug out. They were actually dug out here at Hopkins. But, so she's infected. She's called a functional cure. She doesn't take medicine, may not last forever, but we don't know. She doesn't take any medicine. She's healthy, she's fine. She's fine. Okay, so that introduces the topic of the FIBIG score. The FIBIG is the way to stage disease of HIV in categories. Stage 1 is when the virus is first transmitted. That's within 5 days of transmission. Then at 10 days, the P24 antigen becomes positive. At 14 days, the antibody becomes positive. And at 88 days, the Western blot becomes positive. Now, how do we test people in the United States? We get an antibody test, so we're starting at stage 3, and we get a Western blot as a confirmatory test. And so now we're out to 90 days. We've missed all of that opportunity, all of that. So here's the study from Thailand. It's an amazing study that was just presented at our CROI meeting. They test for the virus. And when they find just the virus at FIBIG 1 and start treatment right there, 92% were like the Mississippi baby. The reservoir was infected, but not enough of it to cause disease. They're functionally cured. They're not treated, and they're doing fine. They have no detectable virus. Downstream, you'll see the FIBIG 3. Now, that's even before, that's way before the Western blot. This is when the antibody and antigen are both present. They had a 50% probability of having a functional cure at that point. They're starting to get out there. So here's how the testing is going. the way, if somebody walks into the Johns Hopkins emergency room or University of Maryland emergency room or Union Memorial emergency room, any emergency room in the state or in the United States, they get an antibody test. So they're down to 5 big 3 right to start with. And then we send off a Western blot. Well, 30% of the people never come back for their Western blot result. We've lost them. They're out of the system. So the way we do it, to me, is not up to speed with current science. And what will happen now is we are going to be testing with what's called a 4th generation test, which is now becoming available. The CDC will be advocating it as soon as it is on the market, which is soon because it's FDA approved and all. And that will test for the antigen and the antibody. But it'd be the antigen. Don't forget, we started with only the antibody. So we're getting closer to the early 5 big. And then instead of having the patient wait for the Western blot, you know what we do now is we say, Mr. Jones, the screening test is positive, but that may mean nothing. So you got to go see your doctor in a month to get the results of the Western blot. And that's when 30% of them never show up for that. So now we tell them right now, we've got both an antigen and an antibody, as well confirmed, and we send them right to care. At the University of Maryland, they just take them by the ear and go right to care. And that's a great way to do it. So there are a number of ways to do this. We're likely to get better. We'll not catch up with the ties for a long time. And this sort of calls attention to that which I just talked about, and that is ties are getting back to the 5 big 1. We're probably going to be up to a 5 big 3. We'd really like to get them early. And that's when they show up in the emergency room or an office. They have mononucleosis-like syndrome. That's when they're symptomatic, but there's another reason to do this. They have the highest viral load and the most likely transmission. A transmission is much more efficient in that early stage of disease. Wouldn't you love to treat them there, not only for their own health, but for preventive health, for protection of their sex partners? And of course, now we have a drugstore test, the OraQuick. It falters a little bit on sensitivity. 1 in 12 is falsely negative, but it's very good in specificity and it's distributed widely and is pretty pricey. It's about $40 a test. But you know what it is in emergency rooms? I didn't realize this. I mean, the test itself is not very expensive, but when you go to an emergency room, they charge a lot. And the reason they charge a lot is they say, listen, we have to have somebody that screens them, we have to have somebody that draws the blood, we have to have somebody that counsels them, we have to send it to the laboratory, we have to get it back, we have to counsel the patient, we have to counsel them to get the test, we have to verify that they approved getting it. And then we have to counsel them in what they need in terms of therapy or no therapy and so forth. By the time we finish, that test costs $200 to $1,000. The sticker label is not necessarily the right thing to follow. This is what we do in our emergency room at Hopkins. We ask patients while they're waiting if they want to have an HIV test or a test for syphilis or gonorrhea or sexually transmitted diseases, chlamydia, and they will say yes or no. Most of them say they do. And then we ask them, do you want to do it yourself or do you want to have us do it? And most of them say they want to do it themselves, and when they say they want to do it themselves, they've got a near perfect record. I mean, you got to see a red line. It's not very hard to. The reason I'm saying this is because I think medicine in the future is going to be very different. I think medicine in the future is going to have a lot of consumer testing, a lot of attention to the speed of diagnosis and application of therapy. The system has to be more efficient than it is right now. And this is what I was talking about before, and it's what's called the Gardner Cascade. Gardner's at the CDC, and what he pointed out is we start with 1.1 million people in the United States that have HIV infection. But then a bunch of them don't come to care because they never get their Western blot, and those that do get it don't necessarily show up for care when it's necessary, and those that show up don't stay in care, and those that stay in care don't necessarily take their medicine. So you have this stair step down. So you start with 1.1 million people that have HIV infection in the United States, and 28% have no detectable virus, which is pretty easy to achieve with the contemporary medicines. So we've got a long way to go with this. This always gets me in trouble. This is what I think may be the light at the end of the tunnel for some of this. It's pay for performance for patients, P4P. That is, you pay the patient in some way in order for them to be a good patient. The person that's the world expert on it is Kevin Bolp, who's a professor at Penn. And these are the questions that I asked him, and these are his answers. My daughter does this. She runs a methadone clinic in New York City, in the Bronx. And she has a fishbowl. She has a fishbowl, and people that show up for the clinic for their methadone care and so forth get to pick out of the fishbowl. They may get a thing that says it's worth a nickel, but they may get a computer. I can tell you, it means a lot to the patient. It is being tested by the NIH, and that's HPTN 065 at the bottom of the test. And what they do is they say, Mr. Jones, if you'll get an HIV test, we'll give you $25. And if it's positive and you show up for care, we'll give you $65. And if you stay in care and get no detectable virus, we'll give $70 every month. Every 3 months. Now that becomes a strong incentive, and but I can tell you it's also very controversial in terms of the ethics of it and so forth. Price-wise, it's cheap. It's only about 1% of the total health care costs in clinics that do it. Now the cost of care of HIV infection is very high. It's about $12,600 a year. This is a disease of poverty. I don't think there's ever been a disease that has so selected people in poverty. Only about 15% have self-pay or resources to pay for their own care. And therefore, it's people that are down and out who tend to get HIV infection. Of course, that's not uniform, but nevertheless, it's the national average. And so the price tag is high. And the drugs are coming off patent. So if you look at the middle of the chart, you'll see efavirenz, the largest selling drug in the United States for HIV infection. Is supposed to go off very soon. 3-TC is on the list, the preferred list. Bacavir is on the preferred list for most guidelines. So we're starting to see two things happen simultaneously. It'll be interesting to see how they play out. One is the drugs going off patent, and the other is introduction of healthcare reform. And that's kind of an interesting collusion because we've not had that so far. I mean, so far the drugs have all been branded. And we really haven't had access to generic drugs. Now all of a sudden we are. And this is an analysis by Rochelle Walensky, who was just here to be inducted in the Society of Scholars, who did the analysis, and I'll tell you what the bottom line was. The bottom line was that if we use generic drugs that are about to be available, we would save about $6,000 per year per patient and save ultimately about $1 billion a year on the basis of contemporary cost of HIV infection. So this is not a light issue. I can tell you what is happening in the field. What's happening in the field is that many providers have been kind of spoiled by the Ryan-White Care Act, which makes these drugs readily available. No matter what we write, the patients will get. And now we don't know how long that's going to last, but the long-term consequences of this, according to Rochelle Walensky's data, would be this: an enormous economic saving, and a patient who would have to take 3 pills once a day instead of 1 pill once a day. And that's the trade-off. And that's the trade. So anybody in this audience has to think of this. If I go to you and say, I can take care of your HIV infection, and you will have to take 3 pills once a day and not take 1 pill once a day, how would you feel if I said they were equally good? And you have to think about that, whether you think this is the right thing to do. I can tell you 1 pill once a day was revolutionary in terms of medical care for HIV infection, because patients were used to a handful of pills. So this was 3 pills in 1 pill, and that's all they had to take. Okay, the next question and final question about HIV infection is, well, will we prevent it? And of course, these are all the different ways that it might be prevented. Condoms I'm not going to talk about. We know they work. We know that people don't use them as often as they should. Circumcision works. It's not necessarily a big issue in the United States, but it is in Africa. Needle exchange we don't have data for, but I think the Maryland data are testimony to what a wonderful program that is. The PrEP is the new kid on the block, and treatment as prevention is the other new kid on the block. The PrEP is giving HIV drugs to people that don't have HIV but are at risk. And universal treatment is we treat everybody that's got the disease, because if they have no detectable virus, they won't transmit anything. At least not this. Now this shows the intersection between STIs and HIV infection transmission, and what it shows is that any sexually transmitted infection magnifies the risk of transmitting HIV. And I think we know that the magnitude of it is between 2 and 4 fold. And therefore, treatment of STIs is part of the AIDS menu in terms of care, patient, and so forth. And that's why the intersection of these 2 circles that don't join very well is probably important. And this is the issue of the first visit and screening. For chlamydia and gonorrhea, we collect the obvious specimens that most people know about, and we send them to the laboratory. And I talked about some of the laboratory problems. The standard laboratory test now is the NAT testing, the nucleic acid amplification test. It's a wonderful test. It's very sensitive. It'll take a day or 2, as I mentioned, in most labs. Some labs will not do a NAT test on non-genital sites, like pharynx and rectum. Some will not do that. Ours will, because because it's not FDA approved as a test. Ours will because you can have by ours, I mean ours at Hopkins Hospital, will do it because they have an internal test that has shown it is valid, and the FDA allows that. Listen, it works. It just depends on the laboratory and how edgy they feel about that restriction by the FDA. But if you can't get the NAT test, then you have to do culture. That'll take time and be pricey. Now, in terms of the treatment for prevention, this is what many people think is the most important paper written about HIV in the last decade. This was a study done in Africa where they took discordant couples. In other words, one of the two sexual partners was positive and the other was negative. They treated the positive and then examined the transmission rate in the group that did, in the patients that were not treated. It was a controlled trial, so half of them got the drugs and half of them didn't. These are the patients with HIV, not the PrEP that I talked about before. There was one transmission in a group that got ART, antiretroviral therapy. It turns out that that was on the first test, and they think it was probably transmitted before the person ever took the drug. I think it's a perfect test. I think it's a perfect solution to reducing or eliminating transmission. This was viewed by Science magazine as the breakthrough of the year in science. Now, that magazine is pretty tough stuff, and it turns out that this is the first time they have ever given their award to a medical breakthrough. And I asked the editor what came in second. I was kind of curious about what came in second. And the answer was analysis of dust on a meteorite over Japan, which gives you some idea about what those guys are talking about. I mean, they're serious about this science. At any rate, this is a big deal, and should be. But I also wanted to mention this. Tom Quinn, in the year 2000, published a paper done in Uganda, Rakai, in which he did the same thing, but he didn't have treatment. But some people have a low viral load naturally. And what he showed is that if one of the discordant couples had a viral load of less than 1,500, it could not be transmitted. Now, every infectious disease in the world is transmitted with efficiency based on inoculum size. So if somebody sneezes in your face with influenza, there's going to be a lot of virus there, and you're likely to get it. But if it's on a fork, you're not likely to get it. There just isn't enough. So this is not going to be the first exception. I think you could have written a rule then. Then the Swiss government came out with a statement that said if you have no detectable virus, you can't transmit HIV sexually. Well, they got blasted so badly by the science community for not having data to support that, despite Tom Quinn's paper, that they wish they'd never done it. Then Greenwich wrote the WHO guidelines, and he said the only hope in the world to deal with HIV is to treat everybody in the world that has it, and that will get rid of it. Universal ART for prevention, and that's now the WHO plan as soon as they can afford it. Then Mike Cohen wrote his paper, the HPTN 052 study that I talked about. And now the British HIV Medical Association has written a review in which they have said, we have reviewed every article that addresses the issue of transmission of HIV infection, and we cannot find any single exception in which a person with no detectable virus transmitted HIV. And now at the end of the article says, and now the rush is on to find a case. My point is that this obviously will work, and it should be a public health policy. And this shows it in area of Africa, where rates were very high. And this is the oral PrEP for prevention, which shows that it's probably 40 to 60% effective in prevention. And one of the problems is getting the people to take the drug that don't have it, and getting regular medical checkups to make sure they have not already acquired HIV infection. We're worried about the long-term toxicity of the drug. Don't forget, you're giving potentially toxic drugs to people for a disease they don't have. You know, it's one thing to give tenofovir to a patient that has HIV because they have a lethal disease, but it's another thing to give tenofovir to a person that doesn't have it. I'm not saying it's wrong to do it, but those are some of the ethical issues that come up in this discussion. So the CDC recommendations on this issue are summarized here. They say very high risk, but they haven't really defined that. And they want regular screening. The prescription can only be written every 3 months to make sure they come back, and they must come back and be tested for toxicity, STDs, HIV, and so forth. So there's some huge challenges here, but I can tell you this is new and hot. And the challenges are primarily in cost, because you can see it's going to be about $9,000 a year. The long-term toxicity, and the possibility that there would be selective use. In other words, somebody would use it only just before they had sex, and we have no evidence that that will work. Now I'm going to mention hepatitis C. It will be brief. First of all, is hepatitis C a sexually transmitted disease? This is a study of MSM in which there is evidence that it is sexually transmitted, and I think most experts in the field think hepatitis C is sexually transmitted, just not very efficiently. I'll tell you what the issue here is going to be. The issue is going to be, does that mean that an MSM has enough risk so that we want to do screening for hepatitis C, only because they're an MSM? And I can't fill in that blank right now. But in terms of hepatitis C, this is a very fast-moving machine right now. It's a very bad disease. There are 4 times as many people have hepatitis C as have HIV infection. Most people don't know they have it who have it. The CDC has said we ought to screen everybody that is in the birth cohort, and the birth cohort is the baby boomers, and that's the people that were born between 1945 and 1965. They have a high rate. The reason for the emphasis on hepatitis C is that now we're about to enter a period in which there is something that is very dramatic. The disease is going to go from untreatable to treatable with morbid consequences and relatively few cures to cures with oral drugs that are easy to take. So it'll truncate. It'll take everything in AIDS and compress it to 2 years. And the drugs are about to be released. So here's the old treatment, interferon, which is punishing drug. And the bottom line is 2014, no interferon, all pills, high cure rate, and a high cost. And the high cost is probably going to be $50,000. It'll be pricey, because all these drugs have to go through all these studies in order to get past the FDA. And that's why that's why all antibiotics are so expensive until the patent goes off. The patent gives them protection, so that's 17 years from now. This shows the mortality, which is now higher for hepatitis C than it is for HIV. So this is the current screening is everybody born in the baby boomer area and era, and all patients that are at risk because they shoot drugs, because they have unexplained abnormal liver function tests. And then the big question is, should they be treated now, or should we wait until 6 months from now, a year from now, when we have access to all these new drugs? And finally, I'm going to say something about human papillomavirus. So this will be the second virus that has a vaccine that will prevent cancer. The first one was hepatitis B. And there are two preparations. One's a bivalent, 16 and 18, the human papillomaviruses that cause cancer, and 6 and 8 that cause warts, genital warts. And I think most people know the recommendations. For women, it starts at age 11 or 12, and then, or catch up, that's 13 to 26, but preferably at 11 to 12. And then for men, it's usually the human papillomavirus quadrivalent, simply because of the way the trials were done. And they also start at 11 to 12. The reason they stop at 26 is because that's when the FDA trial window stopped. So they have data on that group only. Now, if you want to see a vaccine program that is highly successful, look at Australia. They did two things that were unique. They put it in the school, so you didn't have to go to a doctor's office and park, and they paid for it. And their uptake was huge. And what they showed after just 2 years was a significant effect. But what I want you to see is that it was significant for those girls that were under age 18 when the vaccine started. And by the time they got to 18, they'd already been exposed. And that was too late for many. The other problem with human papillomavirus is that it causes anal cancer. And MSM are particularly at risk and a high priority for this vaccine. Now on the CDC list up through age 28. And what this shows is, again, from Australia, the early results which show a preventive effect. Listen, this is going to be one of those vaccines that just works. And it prevents cancer. And the question is, who should get it as a high priority? And what we have said is young people should get it before they become sexually active. And a high priority for gay men. Now, Pilecki is the world authority on this. He wrote the last paper that I quoted. I asked him about this. I said, "What? You only talked about the quadrivalent. Wouldn't the bivalent work as well?" And he said, yeah, it would. But he said something interesting. The quadrivalent includes the two types that cause genital warts. And if you ask a teenager, would they rather have genital warts or cancer? They usually say, I'd rather have cancer than genital warts, which may not be the way adults would answer, but that's the way teenagers answered. So it may be an easier sell if it dealt with the warts as well, especially if they see pictures of the warts. I asked him about the age limit of 26 in MSM. You and I know that if somebody's 28 or 30 or 40 or whatever, and does not already have 16 and 18, 16 or 18, they would benefit from this vaccine. I mean, there's no biologic reason that they wouldn't. The only reason they stopped is because that's when the FDA trial stopped. So I asked him if he would limit that in high-risk MSM that were not already infected, and he said, yeah, it would be reasonable to do that. I mentioned that only because he's a real authority, and I thought it was the expected answer, but not one you're going to get on the wards. And here is the rate of warts, genital warts, in Australia since they started their program in 2004. And isn't that just amazing? Look at that curve. I mean, you just don't see that in infectious disease. So Australia is going to be a country that has almost no genital warts in a few years. One of the problems with the vaccine is it's very pricey. And of course, the price structure in the United States is highly variable. But look at that. I mean, those prices for these vaccines, you have to understand, they have to get their money back for having done all these big studies. But for the consumer, it's punishing. So you're telling the mother, your daughter and your son should get this vaccine, and yet look at the price tag that goes with it if there is no alternative source of support for it. So this is my final slide, and that has to do with healthcare reform. And I told you I was going to show a black box because I don't know what's going to happen. I think the key questions are what's going to happen to the STD clinics, what's going to happen to the HIV care programs, and what's going to happen to the Ryan White Care Act, which are huge enterprises doing actually great work. And if I had HIV, I'd go to an HIV clinic. If I had an STD, I'd go to an STD clinic because of the excellent care that you get. And I think the worry is that this is going to be delved out to primary care, which might be good. It may actually have, in big programs, sequestered expertise. But in a lot of places will probably be just the internist who is actually on information overload cubed. I mean, I don't see how doctors in the future are going to be able to manage all of this tonnage of information. Don't forget, it's not only this, it's also TB. Now, maybe that won't happen, but we can't seem to get answers. I mentioned the issue of the computer, the quality control, the EPR system, which I love, but I don't really love it for a few years because it's awful. I don't know if any of you have taken the EPIC training. There's somebody that's got it. I can tell you, for somebody my age, it's morbid. It's just awful. It's just awful. Yeah, I'd like a baseball bat with that computer. It's just a foreign language. At any rate, eventually it's going to land on its feet, and it'll be great. But I think the transition is going to be very rough. It's going to be rough for everybody, even the people that are very computer savvy. This is a political statement. I probably shouldn't do this, but I said I'm very disappointed that the healthcare reform issue has not dealt with a single-payer system. I mean, I don't know how many of you read Brill's marvelous review in Time magazine, 74 pages long, But boy, I'll tell you, if you read that, you'll say this is a system that is just absolutely broken. Now, you probably don't need that report in order to tell you that, but Vermont is going to do it, and is doing it. And I recently read that Vermont said we're going to be slammed by this health care plan because the turnover to Medicaid in our state is going to add $34 million to our health care budget. But fortunately, we have a single-payer system, and we will be able to save $180 million. I mean, to me, this is just rather obvious. And I think the other disappointment, of course, is the failure to even think about the medical legal issue, which is so morbid in this country. So I'll pretend you didn't hear that last bullet. Now, in terms of what I think is really important to the epidemiology, MSM, black race, and poverty stand out with what I have talked about. That's for gonorrhea, chlamydia, HIV infection, and to a large extent, hepatitis C. The emphasis on HIV infection is testing. And that Gardner cascade, that's so embarrassing. You know, the average person says HIV is a done deal. We've got drugs for everybody. And that's true. And 28% of the people have achieved what is supposed to be easy. And that should make them live a normal lifespan. But look how bad our record is in achieving that goal. For the gonococcus, resistance is huge. We need a point-of-care test. And that would be great to have. And don't forget the test of cure. Test of cure is important to know because of resistance in large part. And because we're not testing sensitivity. We don't know if they have a resistant strain or not. For HCV, the goal is to test and treat. We won't be treated. We will not be the care providers for many of the patients. They will probably go to specialists dealing with liver disease that will assume the role of care provider like HIV providers have in the past. HPV, it's a great vaccine to prevent cancer and warts. Pricey. Australia is way ahead. And healthcare reform, its impact is potentially great. You'll notice that I didn't say whether it was a good impact or not. I think it'll be good, but I think the transition's going to be very tough. At any rate, thank you for your attention.
Thank you very much, Dr. Bartlett. That was great.
Thank you.
If anybody here in the audience has any questions, I mean, we're still in the situation where we are recording now, and it will be archived, but they were not able to make the link for participants outside to be joining us. But if anybody in the room has a question or two, we could do a couple questions now. Otherwise, follow up with Dr. Bartlett later. So any questions right now? Okay, thank you all very much, and thank you again, Dr. Bartlett.
Okay, thank you, Barbara.